Chanel may also be contributing. Dr. Chanel is a doctor of clinical psychology. She also is a licensed drug and substance abuse counselor as well, and she will be talking to us about the distinctions in trauma, the difference between post-traumatic stress and post-traumatic growth. So we got some real good topics tonight. We want you to pay attention closely. Just so you know how the flow is going to go, each panelist is going to introduce themselves briefly, talk a little bit about where they work, what they do in the field, and then we're going to have about a 20-minute discussion on each of their topics collectively. We are then going to break you all into groups, and you're going to have some time to dialogue amongst yourselves in your groups, okay? And then we'll close out, all right? All right, let's give it up for Sister Leila Flowers Brown.
All right, thank you guys so much for allowing me to come. I really appreciate it. Pastor C. It's an honor to be here with you guys. So my topic is chronic mental illness. And what I always like to say is the first thing, 1 in every 100 people will suffer from schizophrenia. So I always say if 1 in every 100 is going to suffer out there, guess what? They're going to be in here with us too. And so realizing that it's not just happening out there in the world, but it's happening here. And so, you know, as I talk about that, and I'm going to talk about schizophrenia, and I'm going to talk about a little bit about bipolar in my little 4 to 5 to 8 minutes. I'm going to get it all in. I'm actually a licensed professional counselor. I have my own practice, caring, counseling, and consulting. I also work with the military service, and so dealing with PTSD, dealing with, you know, soldiers who coming in are having difficulties adjusting. And one of the things I notice when I'm especially talking to the young soldiers, they're coming in the military with disorders that are not diagnosed. And they're saying they don't have it. They haven't went to a doctor. But when I see them, I see it occurring already. And so sometimes just because a person doesn't have a clinical diagnosis doesn't mean they are not suffering. I think realizing that for one. So just kind of thinking about that. So whenever we say that, you can't walk up, do you have schizophrenia, do you have bipolar? Most people go without being diagnosed, especially our elders, because unfortunately, they didn't believe in mental health. And now today, we have to embrace that. We have to change that culture that we have in dealing with mental health. And so kind of thinking about that, whenever I say something that's happening out there, what I want you to really grasp is that it's happening in here with us too. So when we start talking about schizophrenia, and that's just a behavior modification, where the reality is unlinking with the non-reality for people, where what we think we see, sometimes they see something different. What we think we hear, sometimes they're hearing something different. What we think that we feel, sometimes they're feeling something different. And we got to figure out, how do we deal with that? How do we handle that? Because sometimes when we don't know how to handle it, we get all anxious, we start acting all, and then only thing that does is cause them to tailspin into chaos. And so I'm not asking you guys to be clinical, but I'm asking you guys to be relational. I'm asking you guys to be kind. I'm asking you guys to be gentle. And so that's how I want you to look at it. If you feel like you can't do that, then find somebody. Get connected. So when you see somebody that's not in a good place, that you can bring them in, and they can be kind, gentle, caring, and nurturing. The other one I like to talk about is bipolar, because that's the hot buzz going around right now. If you flap the handle, oh, they must be bipolar. And just kind of realizing that that's not what bipolar means. So we have changed the definition. So we really need to start getting closer to that. And really, it's really about some of the symptoms is you have more energy. You know, I stay up past 9 o'clock, and I'm like, but with them, they can stay up for 72 hours. Their reality is that it's about me. I'm right and all y'all wrong, and when you go against that, they struggle. It's about spending money. It's about having a really high sex drive. I mean, we in the church, but that's the reality of it, you know. It's kind of thinking in that vein and realizing that they may come here and they may be in a manic, but the other part is they could be in a depression. They could have low energy. They can have low sex drive. They can not spend any money. But the other part is that they can have a high probability of suicide. And so kind of thinking about that. So So when we start thinking about bipolar, remember, if it's out there, where is it at? It's where? It's in here. So don't think that I'm in the church, I'm safe, it can't be in here. I guarantee you it is in the church. Because guess what we do? We come to church because we're sick and we're trying to get healed. And that's exactly what they're doing. They're trying to find a solution to their mental health issue. And, you know, and Barbara's going to talk a little bit about, you know, a little bit about depression, a little about grief. So I'm going to go ahead and pass it.
Before you pass it, excellent job. Before you pass it,
I was about to pass it.
briefly, the common manifestation. So if I am a parishioner in church and I see I'm not clinical, I don't necessarily know what a diagnosis of a DSM-5 spectrum is, but I see an outward manifestation of someone who is not in a good place. What should my response be? Number one, and then two, how do I discern, or who should I ask to discern between mental illness and spiritual depression?
Okay, and I think I touched on it, but I'm gonna bring it home a little bit. When I was going over this and I was preparing for my vignette, you know, I went to Luke 8:27 through 33. And the story is, and you need to take your time and read it, and what it's about, Jesus ran into this guy, and I'm paraphrasing, so don't go say that ain't exactly what the Bible said either, okay? So what happened, this man, he had been suffering for years and years and years with this issue. And he said, you know, who are you? And this is the part, that's verse 30. And this is where we had to start. We got to say, instead of saying, well, what's wrong with them? What's going on with them? Why are they doing that? You know, the first thing he said is, who are you? The man says, I am many legions, and I don't have the whole thing written out. I think maybe I have. And so when he talked about the legions, the first thing we got to do is, when he asked that question, what was his name? He was being kind. He was being merciful. He was being gentle. And I think when we think about it, is that that's where we need to start at. Because so often we get so intimidated, and you're making me golf, and you're messing up my 5 to 8 minutes, I'm telling you now. I remember, I'm going to tell you the story, and I'm going to pass the buck. When I first started doing my internship, I worked in a schizophrenia ward. So they said, Leila, go over there, and I want you to do a group. And so these are the instructions they gave me. If they start going off and they start hallucinating, just kind of challenge them a little bit and bring them back. And then when I get over there, the lady says, I'm going to be in the window. You make sure you're sitting by the door. And if anything happens, we'll get in there and we'll get you. And I'm like sitting up there. I'm new to the profession. And so I go in and I'm sitting in this chair. And the first guy says, he says, are you scared? And I'm saying, like, in my mind, I am, because this is my first time. I hadn't really done. And the other lady, she's over there having a conversation. And in my mind, I says, if I don't relax, I am not going to get anywhere. And so realizing that when you're dealing with them as a parishioner, the first thing you got to do is manage you. Yes. You cannot help anybody if you're unmanaged. So hopefully I answered that question.
Thank you, Sister Elder Kendrick. Thank you.
Good evening. Thanks again for having me. This is my first time, and believe it or not, I am a little nervous. I know you all say you. Yes, I am. But just to add to what Leila said, and not only to relax, but make sure that you are in a healthy place as well. Yes. And we're going to talk a little bit about that in our small group tonight. But I am a psychotherapist. My passion is grief counseling. I'm a grief counselor here at New Creation. And I've been in grief counseling for several years now, and it's my passion. And every time I have a session here, I learn more and more about myself. When we talk about grief, I work at a local behavior treatment center here, where we have all kind of mental disabilities, different mental challenges, and we go in these groups and we go in these sessions, and they'll come in with bipolar, schizophrenia, and you name it. But the root of their problems, when we talk to them, is they have not grieved. They have not grieved. It could be from a loss of a loved one. It could be from a divorce. I see a lot of that in the sessions here at the church. I'm coming to grief sessions for grieving, but I have not grieved my divorce. I have not grieved my rape at the age of 5 when Dad came in and beat Mama on Friday nights. And so tonight I'm just going to express a little bit about grief versus depression. Believe it or not, church, grief is a thin line from depression. And how do I know? Do I know the difference? And if I know the difference, what do I need to do and how? Unapologetic, seek help, especially in the church. It seems like, and sometimes I grieve because in my profession, I see a lot of parishioners come and say, I can't go back and tell my pastors or my leaders that I'm out here. So what are we saying? We're saying that it's not uncommon for people to question whether you, me, even me, or someone that you know, if they're depressed after the death of a loved one or a significant loss. And another thing I want to say, to add to what we're just saying, we don't have to lose a human being to grieve. Most of you all know, and some of you all don't, that I am a breast cancer survivor twice. And the first time I went through my breast cancer, I didn't know I could grieve that. I didn't know I could be mad with God. I didn't even know that I could cry. But the second time, I learned how to grieve. I learned how to validate my emotions, how to sit with my emotions. And we, as a people of faith community, we don't know how to do that. About 1 in 5 bereaved people will develop major depression. That means that every 5th person that comes in here probably is depressed. We call it clinical depression. And this can often be helped by therapy or medication. But how do we seek that help? How do we know that without being embarrassed, without being an outcast? People that, now I want you to pay especially attention to this because I don't want you to think that, you know, not me. But people that are at the highest risk for clinical depression include the ones that have been depressed already, those who have no support system, you know, the ones that isolate themselves, the ones that go home and don't want to be bothered with people, that set of people. Those who have problems with alcohol, yes, alcohol and drug abuse, are those who have, or even the ones that already have major life stressors. It is important to understand the difference, as we say, between the normal grief and clinical depression, so that the bereaved person gets the appropriate support or treatment. Not just something that someone, you know, on the side of the road tell you what you need, what you should, but the proper treatment. And before we can differentiate between the grief and depression, we need to understand and to have them defined for us. Because some cultures, especially our culture, that's the taboo, grieving. Get over it. Get through it. Put your big girl shoes on. Grief is defined as a natural response to any loss. My pet, my job, my dysfunctional family, any loss. Physical loss, cognitive. You know where I can't think sometime and I can't remember? Emotional behavior and spiritual responses. Do I have faith in God? Where's that? Where is God? Grief is so unique, guys. It's almost like, not almost, it is, just like your fingerprint. Every last one of us have a different fingerprint. And so grief is so unique that all of us grieve different. And some of these things, symptoms that we should pay attention to that sort of give us a hint that we're grieving. Change of our appetite, sleep disturbance, fatigue and exhaustion, avoidance of people. I don't want to be around people. Suicidal thoughts, and the act of it. Here in the church, I had a pastor that was in one of my groups in session, had a local church here, and when he discovered where I was going to church, he was kind of reserved. And he was saying, ma'am, I don't want my congregation to know that I'm here. But we should be able to be able to come to the church when we can't go anywhere else. So what is depression? Depression is defined as a clinical condition, and it can become deadly if it is left untreated. You know that rape that I had at the age of 5? At the age of 10, dad left. At the age of 15, mom left. I haven't dealt with that. And so now here I am at the age of whatever, and my husband dies, my mom died, and I don't understand why I'm depressed, because I have not dealt with those painful events. So in order to be diagnosed with depression, and Leela dealt with a lot of that, we have to be diagnosed by a medical profession, provider. A person must have a certain number of combination of symptoms, sort of something like depressed moods, irritability, loss of appetite, significant weight loss or significant weight gain, sleeping too much or not enough, fatigue, loss of energy, recurrent thoughts of death or suicide. Bob's gone and I want to be with Bob. And we constantly repeat that. I heard Leela say that we need to be kind to one another. We as a church, a faith community, when we hear that on the pews where you're sitting, let's be tentative about what does that sound like. And in our small groups, we'll get into that. I brought a checklist of things that we ourselves can do to hold one another accountable. So if you're finding that you or your loved one identified with some of these symptoms that I have expressed tonight, it's important to consult your physician or a mental health provider. While depression is typical and is treated with psychotherapy and medication, grief therapy is usually treated with individual or group support. And so tonight we're gonna dig a little bit in our small group about grief and loss and how it impacts the church and the underlying painfulness that we experience, that we can get through this tunnel, and not only get through the tunnel, but have someone to go aside of us.
Thank you so much, Elder Kindred. Dr. Carroll, welcome. Can you talk to us a little bit about, we've heard, just a recap, we've heard from Sister Leela, and she's talked about symptomatology and manifestations, common manifestations in the church of mental illness, and Elder Kindred just talked to us about the difference between grief and depression. Can you talk to us from your expertise in terms of how we can arm ourselves specifically around the holiday season in light of what's just been shared?
Okay. I'm very pleased to be here with you this evening. Thank you so much for having me. And yes, the holiday season is a challenge for many people for many reasons. It might be you've been experiencing depression or grief. Grief particularly, it might be a reminder of the first year. It may be the first year. I remember the first year after my mom died. I had a year first, and we all experienced that. So that during the holiday season, you're looking at that, remembering all the things that you used to do. You're grieving your past. You're grieving expectations. We become so unrealistic around holidays. We set ourselves up for expectations that the world cannot live up to. We have to be more realistic, and we also have to reach out. Isolation occurs during this time. You may not get that invitation that you so wanted, or you go and you didn't get a chance to spend as much time with Miss Sarah as you thought you would. Your expectations have to be real and grounded in what can happen, and finding joy in what does happen. And so that becomes an expectation that you can replace all of those unrealistic things with. That there is joy and peace. There is joy in remembering what we used to do at Christmas time. There's joy in baking a cake or spending some time with a neighbor's child if yours is not present. So it's a time for us to just alter our expectations and be as reality-based as possible. Grief is very real, as you indicated, as well as depression. With depression, as well as grief, we withdraw. We isolate. We get angry sometimes. Sometimes it's difficult for us to recognize where we are. Keep someone close to you. Allow someone in your circle. If you are withdrawing to the point that you're not communicating, you need to change that. You need to speak out, reach out. We are a church family. Every one of us here should be attached to something or somebody that you can share with and say, you know, I'm feeling a little low today. Can we have a cup of coffee? Sometimes you encounter people as they walk through the door. I think most of you know I'm a greeter. And you look at people's faces and you want to see where they're at. Some people are closed off to you. But when you see sadness, step to it. Speak to it. How are you doing? Really, how are you doing? Do we need to go over here and speak for a second? How are you really doing? I'm available. And we need to make ourselves available to people during the holidays. It is a very, very challenging time. We don't have as much sunlight. I mean, there are health issues that go on in the winter. People don't think about it. You're not getting enough vitamin D. Mm-hmm. You know, you're not moving about. You're sort of sedentary. People have gone into their little hiding spaces. But we have to pull each other out, do everything that we know to bring ourselves out. But the biggest thing is when you see that you're having challenges, speak up. This thing is real. I heard a very noted, well-known philosopher, theologian this week, and his name is David Michael Copeland. And he said, some of this stuff is real. You need to speak to it. You need to react to it. Yes, pray about it. By all means, pray about it. Pray about it and pray about it. But prayer is action. And you cannot just pray about it and lay in the bed and you know, think that God's going to send you some healing just right down from the sky. It's an action word. And this is real, and you need to address it. And all things are possible through God.
Thank you, Dr. Carroll, so much. Everybody just breathe. Take a deep breath. One more time. Take a deep breath. And let it out. Dr. Chanel is going to talk to us about post-traumatic stress and post-traumatic growth. What is the difference between post-traumatic stress and post-traumatic growth?
Can you smile at me? I know it's some deep stuff here, but the primary thing all of us have heard, well, is there anybody in the room that has not heard the term post-traumatic stress? You don't have to be afraid if you haven't. Raise your hand. Everybody has, right? Because post-traumatic stress is something that's talked about so regularly with our nation constantly being at war. It's similar to what Sister Brown said in reference to bipolar. Everybody has kind of adopted their own perception of what it is, and we've heard the terms, you know, as it relates to combat trauma or childhood abuse or any kind of traumatic event. And I didn't want to spend a lot of time on it because the other end of the spectrum is something that's very, very hopeful. And there is something called post-traumatic growth. I almost said stress again. That's how common it is that when anything negative happens, we assume that that's something that we can never recover from. And in my line of work, having worked in the military dealing with combat trauma, many of the individuals that I saw, their experience was that someone said this before on the panel, that they came to the military with having experienced traumas before they got there. And many times it was an escape from their home environment or the culture that they were in to try to ascertain some level of normalcy. But there's new research that talks about this construct of post-traumatic growth, and that's what I wanted to talk about a little more, because it is a myth, and I know there's a lot of veterans in the room, and I am one as well. We get taught that because we have a negative experience, and there's some benefits, you know, that can be tied to those negative experiences, whether it's compensation or whether it's, you know, being the victim. If I'm injured, sometimes people say, well, how you doing? It's gonna be okay. So we get additional attention and affection because we have become a victim of some kind. So this additional phenomenon called post-traumatic growth is rooted in one's capacity for resilience. And so the thought process is not, I can have a negative experience, but just because I've had this experience, be it rape or a combat-related event or tragic accident or earthquake, everyone has, you know, we talk about Hurricane Katrina and some of the natural disasters that have recently occurred. Well, there are individuals who experience a traumatic event, but they actually have the capacity to grow from that event. And they learn coping, but here, so I'm just gonna tell you a few things that it says. One, the individuals find a sense of new opportunities or possibilities in life as a result of this negative event. In other words, it would be the person who perhaps was an alcoholic, but now they become the counselor, the drug addiction counselor. They shift their focus from woes to how can I learn from this experience? And it's interesting because so many people think that because they have a negative event that they're going to be that way for the rest of their life. And Bishop has been talking several months now, or at least weeks, about perspective. The reality is how we grow and develop or are impacted by a traumatic event is really based in our perspective. If it's extremely negative and we think that there's no light at the end of the tunnel, then 9 times out of 10 there probably won't be. And we are more susceptible to continue to kind of ruminate on that and have the same thought process. And interestingly enough, it spills over into other areas of life. And so the opposite continuum of that is to actually have hope. And so there are not a lot of folks in my field that are teaching post-traumatic growth because, you know, funding and all kinds of things are being sunken into post-traumatic stress. But here are some of the characteristics that the research mentions in terms of individuals that have the capacity for post-traumatic growth. They seek improved relationships with others, whether it's with their loved ones or people that they actually experience suffering with. In other words, they don't isolate. They do the opposite. They actually seek out interpersonal relationships, and they have this intense emotional strength and fortitude. And then here are a few characteristics that are also used to describe individuals who have the capacity for post-traumatic growth. They happen to be, a lot of them are extroverts. They have a capacity for openness, meaning they are more drawn to people than being introverts. This is one of the facts that was interesting to me. It says there are slightly more women who experience post-traumatic growth than men. And I was thinking a little bit about that, and it made me think about just the differences in men and women, and how a lot of times women want companionship. They talk to their girlfriends. They'll call their girlfriend up and say, girl, what happened to me? Guess what happened to me today? Where men are, have the tendency to have more a sense of bravado, and they may not be compelled to do that. And then it says that individuals in late adolescent and early adulthood are more likely to experience post-traumatic growth than little small children, as well as individuals that are elderly. So I just wanted to put us in the mindset of hopefulness that just because we have family members or we have experienced a traumatic event, it does not mean that there cannot be a shift, and that we can't gain some type of hopefulness to transition and have that scenario not impact us for the rest of our lives.
Thank you, Dr. Chanel. It is 7:45. In the interest of time, we are going to have Elder Corey give his 5-minute presentation on the psychiatric hospitalization, and then we're going to field any questions that you all might have. I know this is a lot of information to absorb all at one time, but if you have any questions, please be thinking of what you want to ask so that we can move along. Elder Corey?
So in terms of hospitalization, here in the state of Texas, it's what you call a 72-hour hold, or 72-hour hospitalization. So what does that look like? That looks like when the police go out and they see somebody running butt naked on the highway, then they come bring him in to us. Or that's somebody like that's at a family member maybe at a, you guys are having a party, and he said he see dead people and he want to kill somebody. So typically you're a harm to yourself or harm to others. And so what we do is once you get to the hospital, basically a lot of times you're psychotic, and basically psychotic means you lost reality. You're saying, hey, I'm scared of the dark. So you'll see us, and if you're a male and if you don't want to come to the unit, we're going to physically take you down to the unit. And what we do is what I found out being on the level that I'm at is that sleep helps with mental illness. So we're going to help you go to sleep. And typically what I tell people is I say, hey, look, you're on vacation. You ain't got to worry about paying no bills, because bills trigger things. Just life in general trigger certain type of mental illness. So you don't have to worry about that. Look, we're going to take care of you. You're going to get to see the doctor. We're going to give you whatever kind of meds that you need. So just relax. So if I can take that relaxation from them, and if they can take hold of that, it can help them with their treatment. And that's what we're trying to do. So typically you stay there 72 hours, you're assessed by the doctor, and if the doctor feels that you're able to go home within that 72 hours, you'll go home. If not, you'll stay a little longer, we'll assess you even more, you'll go through groups again, and we'll make sure that you're healthy so you won't go out being psychotic and want to hurt folks. So that's it. Amen.
Thank you. Let's give our panelists a hand. Any questions? Anybody have any questions on something that they heard that was discussed, or maybe that was not addressed that you have a question about? Again, I know it's a lot of information, but we want to make sure. Yes, Sister Joy. Use your big girl voice.
Is it that sometimes it's just mental, or sometimes is it induced by drugs or alcohol?
Typically, yes, ma'am. We have different units where I work. They have a detox unit. I work at a local treatment facility here in San Antonio. And typically we have different units that treat different things. I typically work with the psychotic folks. I'm on what you call the unit called Sabine. So I work with the crazy people. And typically, my end for them, like a lot of them, you're gonna be crazy for a while, but you're gonna want something to eat. So you're gonna wanna talk. So typically what I do is do you want something to eat? Yeah, I'm hungry. Okay, while you're eating, then we'll talk. We'll talk, hey, so how you feeling? So what made you feel like this? Why are you seeing these certain things? And they typically open up while they're eating, because I don't care how psychotic you are, you're gonna get hungry. You're gonna get hungry.
Did that answer your question, Sister Joy? Okay. Any other questions? Yes, I see right here, Elder Latanya, and then we'll get Deacon Teresa.
Question is for Sister Brown. You mentioned that 1 in 100 people have schizophrenia. Can you explain that schizophrenia is not, split personality, and also, and what it is, and also, what are the stats for the bipolar? You said 1 in 100 for schizophrenia, but how many people suffer from bipolarism?
Okay, I gotta move screens. Let me give this book recommendation and I'll get to your question. I wanted to give a book recommendation on post-traumatic growth because I really think it's a good read, because if you can understand how to implement post-traumatic growth in your life, then you'll understand that, one, we do it in some ways, but if you can really grasp it, then you can start using it and it start growing more. And there's a really good book called Bouncing Forward. It says the art and science of cultivating resilience. And they have some really good people in there who had to grow from a traumatic event. And the book is written by Dr. Michaela Haas. That's H-A-A-S. And that's called Bouncing Forward, the art and science of cultivating resilience. And so it definitely gives you, and there's a lot of women in there, and when Elder Pope said that about women, they have a lot of women in his book who have experienced post-traumatic stress, and they have turned that stress into a gold mine. And that's the whole goal. And so if you can just, you can order it on Amazon, you can probably go to Barnes & Noble, but I think the key is that when you hear other people's story, it really shows you what you can really do. So kind of think about that book. Let me go. One of the questions was the stats for bipolar. And I don't think I have the stats on my phone right now. But what I can do, if you get my card, I will get it for you. And so just know that. The other thing, when it comes to bipolar, and I think what you were trying to find out is some of the symptomologies. Is that what you were?
I was specifically saying that a lot of people think that schizophrenia is split personality.
No.
Okay. And so when you think about schizophrenia, it's a break in reality when you think about it. And so, and it can show up, and sometimes people when they talk about schizophrenia, they get confused because they say, is it hallucinations or delusions? And delusions is a totally separate category, so I want to tell you that first. And so really it's a break in reality, and when you think about it, it could be a tactile break in reality, meaning that I might feel ants crawling all on my body, biting me, or I may feel something pinpricking me, or it may be something like, my little phone is not acting like I want it to act. Or it may be something like the voices. Like I may hear voices telling me, calling me abusive language. And so it really falls in the category of hallucination. You can have visual hallucinations. You can have oral hallucination. You can have gastroid hallucination. You may feel like something's in my stomach and I gotta get it out. And so you end up cutting yourself because you think something is in your stomach. And so thinking about it, so you get the audio hallucination when you're hearing stuff and people say, I don't hear it. And I think the hardest thing about when you think about schizophrenia, when you challenge that, you actually agitate the person. So you have to be very creative on how you deal with it. And I'm not saying agree with them, but you got to get them to begin to see there's a break without saying, I don't see that. That ain't even true. Because all you're doing is agitating the person. So I don't know if that answered your question. But it is a difference between the hallucinations and delusions. And so those are two different terminologies when you think about them.
Okay, thank you so much. Can you give your name, please, before you give your question?
My name is Naylisha Scott. My question, you spoke about hospitalizations, and hospitalizations like when they're running on the freeway naked. But what do you do when you have a family member who doesn't do that when they're in the midst of doing things like that? You know, they are a more. How do you get them hospitalized when they're not like crazy 24 hours a day?
Right.
When it's just certain days. I'm sorry.
Right.
Yeah, you know, when they have good days, they may have a week of good days and then a week of bad days. But when they're having their bad days, it's usually at night, away from everybody. But, you know, I get the phone calls.
Right.
So, you know, how do you go about getting hospitalization for someone and not diagnosed as well?
Well, you can bring them into our facility, and they'll diagnose or. And I asked my supervisor the same question, and she told me to tell y'all to call the police, and they'll take them. Yeah. They'll take them.
Let me say
But
something.
I also want to speak to that because that's a very important question. Primarily, the key thing that you said is this is kind of sporadic, but family members need to pay attention to triggers because it appears to the person who's not really paying attention that it's sporadic. But usually there are certain things that trigger certain type of arousal or irritability. But the other significant, thing that you said was sometimes they appear stable and sane. Those are the times to try to have the dialogue around their need for hospitalization. And you don't have to use the word hospitalization. You can use the word help. And you talk to them about quality of life. Mom, dad, cousin, I noticed that things seem to be getting rough for you. You're getting more irritable. I notice you're not getting enough sleep. There are places where we can take you to get help. But in order to get them to that point, rapport is really, really important. And you need to be having a conversation when they are able to receive it. And many times you can call the police, but if they are, you know, I'm fine, I'm okay, it will come down to what he said, which is an involuntary hospitalization. The police are involved typically, and it usually has to be in a time when they're acting out. Because if not, then they appear sane, and they're going to say, I'm fine. So it has to be in a period of escalation, unfortunately.
Also, if you feel unsafe, you know, you can tell the police, hey, this is what he's doing. I don't feel safe. And they'll take him and have him assessed with the 72-hour hold I was talking about.
You have to report that they are a danger to themselves or someone else. Like if, say they're in the house and you have some concerns about them burning the house down or doing weird things like setting fires, or those are reasons why they would be a danger to themselves or others.
Okay. It is incumbent upon us. The hour is growing late. We have 3 questions on the floor. No one else stand. We want to answer these questions as briefly as we can. And if you have further dialogue or further questions that you want to ask, our panelists will be available this evening, or you may feel free to get their contact information and have a private interaction to get your questions answered. Okay? Elder Cassandra.
Little John, the question is mental illness genetic? And if so, can it be prevented, or that detected prior to any outbreaks?
You know, there are factors that appear genetic. There are many factors that lead or result in mental illness statistically. If you come from a family where there have been several members who have been schizophrenic or bipolar, and the environment, in addition to you have family members, then you have an environment that supports that kind of development. If you socialize with people who have that clinical diagnosis, you might develop environmental responses that will lead to mental illness, okay? So there are many factors. Is hereditary one? Yes. Let's just be honest with you. Yes. But that does not mean you have to have mental illness by any means. In fact, that would be a very good factor for the post-traumatic growth, okay? So just because there's mental illness in your family does not mean that you are going to be mentally ill. There are many factors.
And I just want to add to that, one of the factors that we have to think about, if you've had trauma in your history and it's unresolved, that can turn over to, and that's why we have to be proactive. If there is trauma, then you're in a higher propensity to have mental health issues. And so the goal is, and this is what I want you to take away from this, the goal is to get help. Don't leave things unresolved. I think that's the biggest thing.
Thank you. Last two questions, please. Please give your name.
My name is Leon Toinette. I don't know how to ask this question without being transparent. So recently, my family and I have suffered a tragedy, and we are grieving on the world stage, okay? My nephew was killed by a police officer in Birmingham, Alabama on Thanksgiving night. I have been quiet about it because I'm trying to maintain my privacy as much as possible, and I can't answer questions or anything for anyone at this time. But when you are grieving so publicly and the keep getting torn open almost daily with this situation, because information is coming out, and then you go on social media and you see people who you're a part of it, and you know there's comments, there's photos, and everything that's going around. How do you get what you need as far as grieving? People have asked me, well, because I've just recently started speaking on it, but people have asked me, well, what is it that you need? I don't know. This is a different type of grieving process for me and for my family. So yeah, how do you get what you need when you don't even know what you need to grieve?
And you're so right. You don't know what you need. And it's so very fresh for you right now. I think what's coming to mind is you need a gatekeeper. A gatekeeper is someone that's going to keep the doors closed for right now because it's so fresh. And you're still in denial. You're still waiting on that loved one to walk through the door. And you don't know what you need or even how to ask for help. But I'm happy to hear that you do know that you need someone there with you and you do need help. So you choose who that person should be. Someone that's going to be there for you, to allow you to cry, to allow you to talk, and they are listening. And when times come, and it will come, you'll know what you need. You'll know just what you would need. Okay? I'm so sorry for your loss. Thank you.
And thank you for being so courageous to stand up in front of a whole room of people and ask that question. Thank you.
Jesus is Lord up in here. Yes. Pastor C. You know, I am so grateful for the opportunity that each and every one of you shared. But I want to help kind of turn things around a little bit. For 6 years, I suffered with trauma, post-traumatic stress disorder. And what it does is it causes you to continue to revisit every day your agony, your pain, your grief, and the things that have happened to you. Every single day I wrestle. I would pace the floors and eat Xanax like candy. And that still wasn't enough. It wasn't enough. But you know what? I continued to say, somehow I'm going to make it through this. This is not going to determine my destiny. One morning I got up early, I began to worship. Glory, hey, hey, hey. And the spirit of prayer, the anointing fell upon me. And I want to let you know, since I've gotten out of that presence, when I came out of that presence and the anointing, I began to share with the people that could hear me about my testimony. Now I'm in a place where I can say, let this mind be in me, which is also in Christ Jesus. There is a way out. Woo, hallelujah. There is a way out. Praise God. There is a way out. And I don't have to take the medication that I was taking. My thoughts are more into the word, TBN, praise God, and coming back to church. Something is happening again. Something is being stirred up, and y'all can be quiet if you want to. Hallelujah. That is deliverance for PTSD. Thank you.
Thank you so much, Sister Beverly. Once again, we want to thank all of you for your attentiveness this evening. We want to thank our panelists. Let's give them a hand. They will be available after service if you want to approach them and ask some more questions. And at this time, I'm going to turn it back over into the hands of Elder Chanel.
I think we still have time for our quick discussions because we can still be out by 8:15. We did the offering already. So at this point, Pastor, did you have any additional comments as of right now?
I'll wait till it's concluded. I'll wait till the end.
No problem. Okay, so we are going to go over, each panelist has a vignette because the reality is it's easy to talk about mental illness, but when you have no context to define it with, sometimes we're really still not sure. So I'm not going to continue to talk. Our panelists are going to come down and we are going to break the sanctuary into 6 sections really quickly. And each of us have a vignette and we will read it to you. And then we just want you to give us some input on what you think you would do if you encountered this person. And we have about 7 or 8 minutes to do this. So you don't have to move. Our panelists are going to come to you. And I can give you just a moment.
Can we get a little more direction about our groups, please? For those of you who have been streaming with us tonight, we want to say good night to our live stream audience as we go into personal time together. Thank you for our live stream audience. Do join us again on tomorrow night for Bible study. God bless you. Thank you for tuning in.